Okay. All right, everybody. Welcome to our April Grand Rounds. I hope you're all doing well. I can't believe we're already almost in May. Before we get started, I'll just go over some logistical housekeeping items as always. If you're claiming any CME from this talk, please just be sure to put your name, email, and degree in the chat box. And also, we're really hoping to have an engaging discussion and conversation during this hour. So please feel free to place your questions throughout the presentation in the chat, and we'll open up kind of discussion at the last 10 to 15 minutes for any questions or comments anybody has. So without further ado, I will pass it over to Damien to introduce Dr. Bonnie McGregor.
Thanks very much. Hi, everybody. I'd like to introduce our speaker, Dr. McGregor. Dr. McGregor is a behavioral scientist and clinical psychologist. She is the executive director and founder of the Orion Center for Integrative Medicine in Seattle, Washington. Until 2016, Dr. McGregor was an associate member at the Fred Hutchinson Cancer Research Center. Her NIH-funded research there focused on nervous, endocrine, and immune system interactions and testing the effects of psychological intervention on mood and cancer-relevant biological outcomes among cancer survivors and those at risk for cancer. For her work bridging biological research and clinical psychology, Dr. McGregor was awarded the Distinguished Psychologist Award from the Washington State Psychological Association. Because these evidence-based interventions were not making it into clinical practice, Dr. McGregor left Fred Hutch to create the Orion Center for Integrative Medicine, a clinical research center whose goal is to transform cancer care by making integrative medicine part of standard care. Thanks, Dr. McGregor.
Thank you, Damien. Share my screen with you guys all and get this started. There we go. So today my talk's going to be bridging the gap. I feel like I oops, sorry. Just trying to change my view here. Don't need to see all of you. This is going to be a different kind of talk. That's not your usual talk today. This is the first time I've given this talk, and it's the first big talk I've done to an academic group since I left Fred Hutch. So I'm going to start by just kind of talking about how I got here. Long and winding, sometimes road less traveled. And why would anyone want to leave clinical research and start a nonprofit? It seems kind of nuts. And I did really feel like literally I was jumping off a cliff into the unknown and just trusting that each next step would be presented to me as like in that Indiana Jones movie. And so far it has. The second thing I'm going to talk about is, can you still do meaningful clinical research if you leave academia? And then the last thing I want to talk about, and this is what I'd be curious to get your feedback on, is just can we have health economists help us get our proven interventions into the clinic, like the bench to bedside route enjoyed by our basic science colleagues? So that's one of the things. I mean, as you all know, we've got these really successful clinical interventions that just wind up sitting on the shelf. When I left Fred Hutch, Jamie Steigel's paper showing that the second psychological intervention for breast cancer survivors could improve survival at 11-year follow-up had been published. And I just thought, if we can show these things improve survival and then they're still not making their way into clinical practice, what is it that we have to do? And I think the answer is, the lever we have to pull is money. And I'm going to talk about how I'm thinking about doing that. So first, the long and winding road. I started out in graduate school at the University of Miami, working with Mike Antoni and Chuck Carver. There we worked on the cognitive behavioral stress management intervention that I think many of you are familiar with. I think there's a few Miami grads in the Boston area. I'm pretty sure Jamie is there. And I know Tim Sanis is up there. He's not a Miami grad, but he was a postdoc with me, or an intern with me. And then I went from there to do my internship at the VA Puget Sound Healthcare System. And then I went to Fred Hutch. I'd actually started out working in an immunology lab at Fred Hutchinson before I went to graduate school. I was studying immune function in bone marrow transplant patients in the clinical research division, and had just stumbled on the emerging literature at the time showing that psychological stress was impacting the immune system. I was a volunteer with the patients when they came to Seattle for the transplant procedure, saw how stressful it was. And in the lab, there was a lot of the unexplained variance in immune function. I thought, wow, maybe we can actually woke up in the middle of the night knowing that I needed to go to graduate school to become a clinical psychologist to improve immune function in bone marrow transplant patients. So it was great. After my internship at the VA, I got a postdoc at Fred Hutch, and then after a national search, wound up getting a faculty position there. And I thought, great, I've made it. You know, I've stamped my ticket. I said, I've had a whole like 20 years worth of research mapped out, and made it through the promotion up to associate member. And when it came time to go up for full member, I just didn't feel right. I just felt like this was like, I was in too small of a box. And around that same time, I got an unsolicited donation from somebody who'd been in we were doing the cognitive behavioral stress management groups for general cancer survivors, just like the programs that we've been studying at University of Miami. I was running those just as a clinical service at the Seattle Cancer Care Alliance, just to see if we could really do it. I don't think we were charging or anything, but somebody had told me there was no way we could ever do those interventions in the real world. So I was doing it. And one of the participants gave me a $100,000 donation. And she said, I just need a name to put on the check by the end of the week. And I talked to Fred Hutch Development, and there wasn't even really a project that it could be tied to. And so that Wednesday of that week, I formed a nonprofit. I just happened to be meeting with one of the best nonprofit lawyers in the state, who was a mutual friend of ours. And we just hatched this plan over dinner. And by Friday, we had a name to put on the check, and we had the check in hand, and we started this little nonprofit. And that was about 5 years ago. So the Orion Center for Integrative Medicine is a Seattle-based multi-dimensional consortium of healing providers working together. We provide cutting-edge, evidence-based integrative care for those touched by cancer. Everything we do has at least some empirical support. And I believe that we transform cancer care, we expand the science, and complete the cure. I always tell my patients this is the best time in history to have a cancer diagnosis, because there's so many people that are living with what had been formerly terminal diagnoses. And some of the work I do in my clinical practice is actually helping people come to terms with this, what is almost like a Lazarus effect. They should have been dead, and now they're alive. They kind of come to terms with their death, and now part of their work is just to re-embrace life again. So it's a great time to have a cancer diagnosis, but there's still a lot of work that we need to do. So the Orion Center, in a nutshell, I feel like we provide this sort of circle of support around patients. We have acupuncture, we have nutritional counseling, we have psychotherapy, we have 2 psychologists, myself and my colleague, Anna Charbonneau. The Health Smart program is kind of under our auspices. We've got oncology massage, and we've got Reiki and energy medicine, which there is an emerging empirical literature supporting it. And our patients love it. This is from our impact report that we just put out last month. So in psychotherapy, we had almost 2,000 sessions. This is just last year. We also have a low-cost therapy option. I've got 2 graduate students from Seattle Pacific University's clinical health psychology program, and they come and they can see 2 to 3 clients under my supervision. And these are usually cancer survivors who are younger and don't really have good insurance or insurance that would cover their psychotherapy. So it's just a flat rate, $40 per session cost, and they get great care and good supervision, I think. Our nutrition, the psychotherapy and nutrition, we all went online at the start of the pandemic. So our numbers are about typical for what you would see on a regular year. Acupuncture and our energy medicine and massage, of course, they were offline for 2 to 3 months because of COVID. But you can still see we saw a number of patients and had a number of sessions. And these folks are not here. They're only here a few days a week so far. We're still pretty young and growing. And here's what our clients say. It's actually really satisfying work. I had a client who I met at the first visit. She was a metastatic breast cancer survivor. She was diagnosed at stage 4 because she had pain in her back and she had metastases to her spine. And she now has no evidence of disease. She's made it through treatment. She's just going through reconstruction, and she's in our Health Smart program right now. And she said, how do people make it through their cancer experience without Orion? I honestly can't imagine how I would have navigated my diagnosis and treatment without the support I got from Jessica, the acupuncturist, Jen, the oncology massage person, Bonnie, and Gretchen, our nutritionist. So I got to say, it's really rewarding to do this work. So the Health Smart program, I'm not spending a lot of time on this because I thought that there were folks there that were doing your stress management and resiliency training program, which is very similar to Health Smart. I think we both have similar origins in the University of Miami, and so they've kind of evolved a little bit differently. But the Health Smart program, as it stands now, is called Stress Management and Relaxation Training for Health. This is the logo and the branding that I had for when I was doing my research at Fred Hutch. It's based on the University of Miami B-Smart Cognitive Behavioral Stress Management Intervention. So we've rebranded it. And then Susan Leckendorf and I spent the last 5 years modifying the Miami program, the CBSM intervention, specifically for ovarian cancer survivors with patients who are presenting with a little bit higher acuity. So we made it more intentionally mindfulness-based. We added acceptance and commitment therapy, and we also added spirituality and mortality, because ovarian cancer patients have such a high mortality. We felt like we needed to address it directly. So basically it's 10 2-hour sessions, plus we've added an orientation session. We took a lot of stuff from what used to be in week 1, introductions, housekeeping details, and put those in an orientation session, because we were delivering these all online. And we needed people to have a chance, or we used to have to show people what a Zoom session looked like. It's pretty funny now because everybody knows what it is, but just giving people, especially some of the participants who are a little bit older, we wanted them to have a chance to make sure they could log on correctly. They'd been trained by the University of Iowa's students supporting the program. And so at Health Smart, we do the same thing. We've got 10 2-hour sessions plus an orientation session. Some of them are in person. Some of them we started moving to completely online in February, before the pandemic actually. They've got 10 relaxation recordings. They get video access to the group. So when we were meeting in person, we had a big screen in there so people could be either in person in the group or meeting with us remotely if they were sick and couldn't attend in person. We have a 1-month follow-up group. So once people are through with the intervention, they can do a 1-month follow-up. That's because most people feel like they can't imagine not being in the group. And we just kind of cut them loose with a plan for maintenance. And then we check back in with them in a month and see how they're doing. And then they realize by that point that they can make it without us. And then if they want to continue to support their work, we have a monthly alumni group for graduates, and that's run by our graduate students as part of their training program. And it's been pretty successful. We had 12 participants joining last month. So just for those of you who are familiar with the stress management and resiliency training program, I think that's 8 weeks that you guys have. This is kind of what ours looks like. We've got like week 0 is orientation, and then here's the different relaxation exercises we do. We teach deep breathing. Week 1 is introduction with deep breathing and progressive muscle relaxation. Week 2, we start to go more into cognitive behavioral therapy with automatic thoughts and cognitive distortions. We do PMR and beach scene imagery. 3 is rational thought replacement and autogenics. Week 4 is coping. Used to be weeks 4 and 5 were coping, but we compressed that into 1 week, and we do color meditation that week. Week 5 is acceptance and commitment therapy and gratitude. This is the week where we really focus on fear of recurrence, and we felt like acceptance and commitment therapy was a really great technique to use for fear of recurrence, because it's not necessarily a cognitive distortion. It's a very common concern that cancer patients have, but in our mind, we want to make sure that it doesn't stay in the driver's seat. The analogy that I always give is if it's in the driver's seat, if fear of recurrence is in the driver's seat, it's going to take us to the bad parts of town. So we just kind of acknowledge it. We don't want to get rid of it because it's keeping them doing all their health behaviors like diet and exercise and stress management groups. But we put it in the back seat in a little car seat with a 5-point restraint, and pat it on the head and say thank you. And then you get in the driver's seat, and then you think about, well, what's important to you? What gives your life meaning? And once you're in the driver's seat, you can head the car in that direction to those things that are important for you. And it seems to be really helpful. We had a participant last week who we had just covered that, and she had to go in for her scans, and she's a metastatic survivor who's living with no evidence of disease right now. And she was really able to use those techniques to help her get through her scans last week. So that was really satisfying. Week 6 is social support, introduction to meditation, and then communication skills and anger management. And 7 and 8, those are also to support our social support networks, maximizing those. And we do even more meditation training there, mindfulness, and then loving kindness meditation. And typically, by the time we get to week 7 or week 6, actually, people can drop into a nice meditation practice. They kind of work their way up doing the progressive muscle relaxation and the the guided imagery. They've had an opportunity to bring their focus inward and get comfortable with that. So they can just step right into the meditation pretty easily at that point. Week 9 is light imagery, which is another guided imagery, and week 10 is enchanted cove. And then during the 1-month follow-up, the participants get to choose which exercise they want to use. Participants say, I didn't know I needed this workshop. It's been hard to describe to people what it is. Most people says this isn't what they say this isn't what I expected, but it's even better than what I expected. It's been a game changer. I don't feel alone anymore. This was an ovarian cancer survivor who, when we first met with her, she was in bed in her mobile home in rural Iowa. And by week 4, she was back at work cooking at a VFW hall as a volunteer. So she met with us in the pantry. You could see bags of onions hanging behind her. It was really amazing. And I had one of our participants say, I think every cancer patient should go through this course. So our preliminary data, we are collecting data on this. This is just a real world setting, delivering an empirically supported intervention in a real world setting. So we collect data pre-post intervention. So it's pretty simple. It's more like we're calling it a program evaluation. So we've had 45 participants to date. Our attendance rates are always above 95%. We've seen significant reductions in perceived stress and depressive symptoms, and also cancer. We just published our first poster with these findings at what was it, APS, I think, American Psychosomatic Society, virtually, of course. So where do we go from here? And this is where we're moving into kind of the second part of the talk. So right now, we're concurrently doing a randomized controlled trial of the Living Well study while we're continuing to collect data on HealthSmart in a real world clinical setting. So in my mind, it's kind of cool. We're testing, which is basically the same intervention with ovarian cancer survivors in the Living Well study, which I'm going to talk about next, while we're also running the HealthSmart intervention, which is for generalized cancer survivors in this real world setting. And they kind of feed each other. We learn, I think of the work that I'm doing here at Orion with general cancer survivors is kind of like our test kitchen for making tweaks and putting final touches on the intervention. And then what we learned during the intervention study is helping us improve what we do in HealthSmart in the real world too. Then I'm going to talk about creating a for-profit entity in the Orion nonprofit. This is a way to think about getting the HealthSmart intervention out into the field. One of the things that in Seattle, was a very successful smoking cessation program at what used to be a group health cooperative, which is now part of Kaiser Permanente. And the group of investigators that had that successful smoking cessation program actually went and formed a company, a for-profit company, had a nice office downtown, and they were also benefiting from a lot of the tobacco money that was out there, but they were delivering their intervention using telehealth to people all over the country. And it wound up being bought up by some pharmaceutical company, and they've done very well. But in my mind, it was a really successful way to get a proven psychological intervention out into the community. So we're thinking of trying something like that. If we do these HealthSmart interventions completely online, we can deliver them all over the country. That's what we're doing in Living Well, and have control over the dosage and the intervention that we're delivering. But first, we're going to start by just running groups statewide. We've expanded our reach with these programs out into the Olympic Peninsula and then into Eastern Washington across the Cascade Mountains from us. Yes. Then we're also going to be talking about tracking cost data with HiCor, which is the Hutchinson Institute for Cost Outcomes Research. And then I want to talk a little bit about funders, like who should pay for this? How should we pay for this? Is it third-party payers, the hospital? If we're talking about bundled care and paying for outcomes rather than paying for procedures, it might make sense for hospitals to pay for this because I think it's going to improve their cost outcomes. Right now, we have insurance paying for them. People are paying for them out of pocket, and also philanthropy. But next, I want to just talk a little bit about the Living Well study, because that's the study that's happening right now. It's the RCT testing the same intervention that we're running here in our real world setting. And I know Susan Leckendorf was just speaking with you guys, I think it was in October. So some of this is familiar. I'm just going to give you a little bit of a reminder. Living Well is reaching out virtually to rural and urban ovarian cancer survivors. It's a It's a multi-site trial with the University of Iowa, the University of Washington, and the University of Miami. Susan always says we draw a diagonal line across the country. So it's really interesting trying to figure out the time zones when we're getting a group together. That was kind of a tricky thing, but we figured it out. So I don't know if most of you know, you probably do. Ovarian cancer is the second most common gynecological cancer. It's a localized disease, or if it's localized, there's a 95 or 92% likelihood of 5-year survival. The problem is that it's really hard to diagnose. And so most people are diagnosed with advanced stage disease, and their 5-year survival rates are from like 29 to 48%. And it's even worse if you're over 65. Susan Leckendorf has done a ton of work over the years, just showing beautifully how social support and other stress-related factors have a profound influence on the pathways related to progression of a variety of tumors, but in particular, ovarian cancer tumors, showing that the tumor-infiltrating lymphocytes are impacted by stress more profoundly even than the peripheral blood lymphocytes, showing that if you add VEGF to cell cultures of ovarian cancer cells, they kick out boatloads of VEGF. And Neil Sood then took that work to MD Anderson and showed in his mouse model that chronic restraint stress caused increased vascularization of the tumor, increased tumor growth, and you could block it all with beta blockers. So Susan just got to the point doing this basic science research, also showing that social isolation and distress were associated with poor prognosis in ovarian cancer survivors. She just got to the point where she felt like she needed to do some sort of an intervention. There were clinical implications to this. We need to have multimodal interventions for distress, sleep, social isolation, stress management, and also gratitude, enhancement of well-being, mindfulness. There have been some talk about doing pharmacological interventions. I think there's a couple of trials going out there using beta blockers, because Anil showed that you could block all these effects by administering beta blockers. We felt like we could do better than that, that if distress and social isolation were causing a lot of these things, it made sense to us to treat it with a behavioral intervention. And just another point that she wants us all to know is that biobehavioral factors may be important to consider in chemotherapy trials, because we're showing that chronic stress is not only related to increased disease progression, but also chemo resistance, in part because I think the stress is associated with increased rates of DNA damage and poor repair. And so you can imagine the cells are mutating more quickly. And so the possibility of a mutation that allows the cell to escape the chemotherapy is greater. So it makes sense to intervene with ovarian cancer patients because they do have high rates of depression at the time of surgery. And also afterwards, they have high rates of sleep disturbance that tend to persist out to 1 year. 21% are still depressed 1 year post-surgery. And I need to move this. Sorry. Oh, rural patients have greater distress than urban patients, which is why the grant is focused on rural and urban patients. Uh-oh. Oh, there we go. That's just showing rural. You can see the dark areas in that picture are rural areas. There's a lot of them in Iowa. So we know that psychosocial adaptation following primary treatment, there's critical periods. With my clients, I always tell them that most of the time I see them coming in to work with me to do the emotional healing after they're done with their treatment, because during treatment, you're just so focused on the treatment, getting your body through it. So there's a critical period, a re-entry period between treatment and 1 year later. The early survivorship period can go out to approximately 5 years post-diagnosis. I've had people come into my office 3 years after the end of treatment, and they say, my doctor says I don't have any cancer. My family says, why can't I get back to normal? And I should be happy, and I don't know why I don't feel better. And it's because they haven't done the emotional healing. There's also a lot of latent effects that pop up during this time, peripheral neuropathy, fatigue, troubles with the gut microenvironment. I mean, they don't really hear this when they're going in for treatment. I don't think they could, but there's just a lot of work still that needs to happen after the end of treatment. The period following active treatment is pivotal. I've heard patients say it just felt like they got spit off the end of a treadmill. They had 150 appointments on this treatment treadmill, and then at the end of it, they just spit off into the survivorship abyss, and it's stressful for them. They feel like they're not doing anything to treat their cancer. It's a time to readjust to normal. When do I get to be a healthy person again? And so we feel like this is an optimal time to intervene. And like I said before, the new normal includes adjusting to lingering emotional and physical effects, fear of recurrence, which is huge and a really significant worry for ovarian cancer survivors because they do recur. Depression and anxiety symptoms, like I talked about before, fatigue, cognitive difficulties, pain, and neuropathies. And so Susan and I spent about 5 years building this living well intervention. We took the cognitive behavioral stress management intervention from the University of Miami and thought we want to make it more intentionally mindfulness based. It's something I'd been wanting to do for years. While Susan was doing her basic science research, I was doing intervention research, had even developed an intervention for ovarian cancer survivors during my postdoc at Fred Hutch. And so I was familiar with working with ovarian cancer survivors, and it was like this kismet that we could kind of bring our resources together and create this. And so this is just a paper that Ellen Kinner, one of her students, published showing our preliminary results and kind of how we built this thing. It's all web-based. This is our web platform. You can see when the participants land on the web platform, they can go to their daily relaxation, where if they click that, they get all 10 relaxation exercises. And they're asked before and after, how stressed are you? So we can track their stress before and after relaxation practice. Here is the daily reflection, which is a chance for them to write something that gives their life meaning, something that they're grateful for every day. And this button, if they push that, they get a weekly overview. I'll show you that in just a minute. And in the weekly overview for each of the 10 weeks, they can click through about 5 slides just so they can get if they don't have time to read the book before class or want to go back and review something, they've got it in an easy to read format. And then the last button says WebEx sessions. We started out with WebEx and it sucked. And so we went to Zoom and we're really happy with that. And it's been great, as many of you know. So we showed that it addressed a major unmet need. It is accessible in remote areas. If people don't have internet access at home, like Wi-Fi, if they don't have a device, we send them a tablet. If they don't have Wi-Fi, we send them a tablet with cell service on it. If they've got a computer and they don't have a video camera, we send them a video camera. So we pretty much we give them what they need to access the program, and provides really important social support. We've had people in these groups that said they've never met another ovarian cancer survivor. So in our preliminary results, we found that it was feasible, acceptable, it improved quality of life, it reduced stress and depression, and also improved social support, those were all the things that we were targeting. So we felt pretty confident going into this. We had some really nice preliminary data to write our R01, which actually got funded on the first time, thanks to Susan, she's amazing. And so the R01 the primary aims are to test the efficacy of a 10-week group-based web-delivered psychosocial intervention versus a health promotion intervention for ovarian cancer survivors. The comparison group was really important to us. We didn't want it to be just something to babysit the people. We wanted it to be something that would be really meaningful for them. We worked with ovarian cancer advocates, talk about what is it that you really want to learn more about. So we feel like it's a series of lectures basically on health topics that are meaningful for ovarian cancer survivors. And I'll show you more about that in a minute. So our primary outcomes are health-related quality of life, perceived stress, depressed mood, anxiety, and fatigue. I know ultimately Susan's also going to be wanting to look at biological outcomes, but we'll have to write another grant to do that. And then our secondary outcomes, our secondary aims are looking at the effect of the intervention across rural versus urban participants. Does the intervention delay recurrence status? And then also looking at it by age and disease stage. This is, like I said, this is a multi-site study. And so this is kind of the design. We've got 3 institutions, the University of Washington, the University of Iowa, and the University of Miami. We also have oncologists or gynec docs in Montana and Alaska and Green Bay and Washington University who are helping us recruit their participants. Susan and I just got done doing our little dog and pony show with these rural offices with the nursing staff, telling them about the program and how they can help us recruit. And then I have to say the nurses are just so excited about that. They actually want to have access to the the comparison group materials too. And they asked if they could do it because they were so excited about it. So that's been really, really satisfying. We're also recruiting through the Ovarian Cancer Research Association. They've got a great social media presence that they've been helping us with. And the Clarity Foundation, which is a really amazing nonprofit that works specifically with ovarian cancer survivors to help them with treatment planning. And also they provide 10 weeks of free psychotherapy support for ovarian cancer survivors. So we're going to randomize 256 patients who are up to 3 years post-treatment. So between 0 to 3 years post-treatment, and they'll be randomized either into mindful living or healthy lifestyles. This is what the mindful living, if you click on the overview, this is what you will see. And this just kind of shows you the different weeks. It's pretty similar to what I showed you before. Stress and awareness is week 1. Automatic thoughts, cognitive behavioral therapy, cognitive restructuring is in week 2 and 3. Week 4 is acceptance and commitment therapy for fear of recurrence. Week 5 is coping. Week 6 is social support. 7 and 8 are communication and anger management to support getting the most out of our social support networks. Week 9 is life goals or spirituality and mortality. Can you confront your mortality and also maintain hope? That's our goal with that. And then week 10 is just showing how it all fits together. And we've got this great Venn diagram that shows how everything works together. We actually have participants take their workbooks with them to their doctor's appointments. There's a daily relaxation, or each week they get a new relaxation exercise, which are similar to the ones that I showed you before. They also have daily gratitude or meaningful moments and a weekly group meeting. And also the 1 month follow-up, or they do have follow-up sessions. They've got 2 follow-up sessions in this. So the healthy lifestyle ones is, I don't know why this slide does this, but I'm just gonna. So we start out with just ovarian cancer 101. Each week we've got a 30-minute video recording of an expert talking about the content area. So we've got a gynec doc talking about different types of ovarian cancer, different kinds of treatment, what's a PARP inhibitor. Week 2, we talk about quality of life. Most patients haven't heard about that, and like, how can you improve that? And then the next few weeks are all talking about things that they can do to improve their quality of life. In week 3, we talk about exercise. Week 4, we talk about nutrition. Week 5 is sleep. Week 6 is stress and health. So it's just a little primer on stress management. Week 7 is chemo brain. Week 8 is probably one of our more popular ones on body image and sexuality. And week 9 is integrative medicine and survivorship care. And then week 10 is just a review of everything. And so far, people have really, we've run one of these groups, we've finished one of them, and we've got one that just started again. And our attendance rates have been great. They've been over 90% for this too, because people really enjoy it. We have nurse educators teaching these classes. Susan and I tried to teach, well, we did teach the first class, but it was so hard for us not to be therapeutic while we were doing it. We had to sit on our hands, basically. So we knew that we could not have therapists leading these groups. But the nurse educators have been great. They found just the right sweet spot between being compassionate and delivering the material without allowing too much the social support and the things that would actually confound some of our outcome variables. So the design is, it's like I said, it's a multi-site study. We're going to recruit 256 ovarian cancer patients from those 3 main sites, and then the other rural sites and the social media and the Clarity Foundation. The inclusion criteria include completing your primary chemotherapy in the last 3 years, not on active treatment. Maintenance therapy is okay. And if you have a recurrence during the study, that's okay. You can stay in it, although sometimes it's hard for participants because the chemotherapy is pretty tough. We can have people in the group that have had 1 recurrence, but not more than 1. And we have to have right now people proficient in English and not demented. So then they're randomized and we do a pre-assessment. Then they're randomized either to the intervention or which is living well or mindful living or health promotion. And then at follow-up, we've got a post-assessment, then a 6-month assessment and a 12-month assessment. And they'll get a 1-month post booster session right before the post-assessment, right before the 6-month assessment. And then they get a 6-month booster session right before the 12-month assessment. We had somebody help us design the flyers. We had a nonprofit marketing firm work with us. I thought they turned out kind of cool. And I just think that's something that when we're thinking about doing study design or recruitment, I think very often we think, oh, we can just design a flyer. How important can it be? But I do think it's important to use experts in this area, because I think it really makes a difference in engaging your participants. And this is something I learned when I was working with the Clarity Foundation. This is the group that does their marketing for them. So right now we started recruitment in September of 2020, right on track despite the pandemic, which was quite amazing, especially given the pandemic. But because everything is all online, it made it, actually, we didn't skip a beat. We've so far, as of last week, recruited 64 participants. We've run 3 groups have been randomized, and now 2 have been completed. And our attendance in both types of group is still well above 90%. So that's good news. And it seems like recruitment's starting to pick up, which is what you like to see. And these are just all the collaborators. You can imagine it takes a pretty big team to get all of this work done, but it's really fun. And I guess the answer is, can you still do meaningful clinical research in a nonprofit setting or once you leave academia? And the answer is yes. It's been really fun doing this work with all these folks. And then the last part of my talk is going to be just looking about, can health economists help us get our proven interventions into the clinic, like the bench to bedside route that our basic science colleagues enjoy? When you think about it, the pharmaceutical industry can take those basic science findings, and then they can do the big phase 3, 4 clinical trials and marketing and dissemination, getting them out into the community. It's big business, and that's why the drugs cost so much money. But the stuff that we do is relatively cheap. There's not a lot of money in it, and so there's not really an incentive for that. And I think the incentive for us is going to be showing that we can improve cost outcomes. Like if you do this, if you give integrative care, starting with, I want to start with psychological intervention because that's where our data is the strongest. If we give people psychological intervention, will that improve the cost outcomes? And that's going to be more meaningful as we start to change how we reimburse for healthcare. So cancer is a great place to be doing this work because it impacts many lives. It's a big business. When you go to the ASCO meetings now, you see people in 3-piece suits walking around, the bankers, the biotech company owners and investors. It's a big business because there's a lot of cancer survivors. As of January 2019, there were 16.9 million cancer survivors, 1.9 million new cases diagnosed in 2021, estimated. And then in the number of estimated deaths is 608,000, which is interesting. Now those numbers mean something because we've been looking at COVID deaths in this country. The number of cancer survivors is increasing. Cancer is a disease of aging. We're getting older as a population. Survival rates are increasing. So I can tell everybody it's the best time to have a cancer diagnosis. This year, it's estimated that 68% of all of those diagnosed with cancer will survive 5 years or more. So right now, there's about 17 million cancer survivors, and that number will only grow. So I guess this is, we're showing that there's going to be demand for this. And as the numbers are increasing, of course, the financial burden is increasing. The US cost for oncology services and medications is expected to increase from 183 billion in 2015 to 246 billion by 2030. It's a 34% increase. And this is just based solely on population changes due to aging and growth. And this doesn't even include a lot of the cost of the cancer drugs, or this number might be much higher. This is just Medicare data, so it's not really covering all of the picture. So it's even worse than this, or more expensive than this. As I said, survivorship comes at a price on many fronts. There's changes in physical appearance and functioning, fatigue, cognitive difficulties, or shortened future, fear of recurrence, pain, changes in sexual functioning, altered financial status. I mean, cancer diagnosis can really take a major hit on your finances, and bankruptcy is a significant predictor of mortality, and it can change social relationships. So we know psychological interventions are effective. I don't need to tell you guys this. We've shown over and over they can reduce distress and anxiety and depressed mood, improve social support, enhance quality of life, enhance emotional growth, or benefit finding. They can improve immune function and constitutively transcribe response to adversity. Steve Cole's panel of genes that are upregulated or downregulated in response to adversity. There have been a number of studies that can show have shown that this talk therapy, including the cognitive behavioral stress management that we talked about earlier, can actually change which genes are turned on and off. And over time, even at 12 months after the end of the group, you can see the good genes are continuing to be upregulated and the unhelpful genes are being downregulated. And 2 studies have shown that it can improve survival in breast cancer patients. And so I thought, great, if we can just show this is going to improve survival, there's going to be uptake by the clinical community, and these are going to become part of standard care, but that's obviously not the case. I was very naive. Showing improvements in mood and immune function and survival is not enough. So how do we make integrative medicine, including psychosocial interventions, standard care? And I think we need to show that integrative medicine improves cost outcomes. And I want to start with our psychological intervention. So unfortunately, there's not a lot of, I've been reviewing the literature periodically, and this is still the best one that I can find, looking at the cost effectiveness of psychosocial interventions in cancer care. This is by Linda Carlson up in Alberta, which is great because they have a single payer system. So it's a great place to be looking at this. And surprisingly, they found there's very little data looking at cost effectiveness in psychosocial interventions in cancer care. There was one study that they showed that did have it saved like $217 per patient, just a little 6-week cognitive behavioral therapy intervention. And so I think there's plenty of room for work. There's plenty of reason to believe that it could be the case, but nobody's really done this work. But if somebody knows of something, please let me know. So when I was at Fred Hutch, just down the hall from me was the Hutchinson Institute for Cost Outcomes Research, or HICOR. Great group of folks, ran into them in the lunchroom, got to chatting. They started having these annual symposia where they would talk about value in cancer care. They have, over the years, gotten access to the claims data in Washington State from over 70% of the cancer patients. So they can do things like look at each clinical institution has an NPI number. And so they can look at NPI numbers and the different types of diagnoses and costs and see which, and they've got quality metrics too, like have you been readmitted during your chemotherapy? Have you had an emergency department visit? So even just looking at claims data, they can get this sort of big picture idea of how well patients are doing and how much it's costing. So this is the report that they put out in 2018, where I just got this idea. It's like, oh, we need to show that we can improve value in cancer care. And actually, if you see right here, this was my office at Fred Hutch, and the HICOR folks were right down here. So value is quality divided by cost. Summary quality score represents a clinic's overall quality relative to the regional average. And so that is, again, things looking at like how often were your patients admitted to the emergency department? How many unnecessary scans did they get? How many times were they hospitalized during chemotherapy? Things like that. And then cost is just a risk standardized average episode cost per patient associated with each measure. Includes all the reimbursements paid by health insurance during the episodes, and it may include non-cancer costs. So if you get an infection, then it'd have to be treated for that. That would be in that. And then they create these really interesting graphs, which this was my aha moment. So I'll just walk you through this. You can see on this axis, this is increasing cost, and this is like per person. And so it starts like about 40,000 and goes up to, I think that's 65. And you can see there's the name. These are all the cancer centers in the Seattle area: Virginia Mason, Swedish, Seattle Cancer Care Alliance. And so the gist of it is, if you have on this axis is value or quality. Sorry, it's quality. Cost goes this way. So here's increasing cost. Here's increasing quality. And so your goal is to be over here. Can you provide high quality care and have it cost less money? And it turns out that if you do provide, and this is just looking at hospitalization during chemotherapy, if you take, it's great news, because if you take better care of your patients up front, it's going to cost you less money down the road. And so the Everett Clinic, their cancer center, it's a consortium, was set up by nurses, and they do a really good job of checking with their patients on Friday afternoon to see how they're doing, so that they don't wind up getting admitted over the weekend because they're dehydrated. And this has had a big impact on the cancer centers in the Seattle area. You can see Virginia Mason here. It was on the low, and it's lower than average quality, and it was just a little more expensive too. Virginia Mason, over the last 3 or 4 years, has really upped its game. So has Swedish. After this report came out, they started taking doctors from the Seattle Cancer Care Alliance, recruiting them, and they have really upped their game too. So it'll be interesting to see if they do this report again about in a few years, which I think they will. But I think my point is that we want to be in this box here. And I think that because what we do is so inexpensive and can make a big difference, I think we can make a big difference in some low-hanging fruit, like going in for reducing ED visits or unnecessary scans. Some of these scans are just due to fear of recurrence. If we can take care of our patients, have them do better, they're going to cost less money. And I think that's what's it's going to take to get us into standard care and get uptake. And as we start to change the way we reimburse for care, I think this will make a big difference. So our goal is to help all of these clinics be in this high quality, low cost box. Another way to look at this, and this is from an AIMS page that an investigator at HiCor and I had put together right before the start of the pandemic. So of course, since the pandemic started, they've had to totally pivot, but this is what we're going to be doing in our post-pandemic time. So we're going to examine economic benefits of the psychosocial intervention in a real world setting, which is Orion. We can determine cost and quality adjusted life years and health smart versus matched controls. And we can do this just by assigning the Orion NPI number to our participants. And so we would look just like one of those hospitals I just showed you on the previous slide. And we can, just using our NPI number, we can track patients that are stamped with our NPI number and compare them to matched controls to look at costs that way. It's a really simple and passive way of doing these analyses. We can also measure quality years and that quality is a metric that reflects both duration and quality of life over a given time horizon. This is something the health economists talk about a lot. It's a reference standard outcome of economic evaluations worldwide. So this is kind of like the gold standard when you're looking at health outcomes in economic terms worldwide. And so we get that by applying health state utility values, measures of preferences for health states. And this is elicited directly from patients using quality of life questionnaires and the amount of time that they spend in these health states. So it's all, the health economists are better at describing this than I am, obviously, but it's just another metric that we can use. So we can look at just cost, kind of like I showed you on the slide ahead before this, like do the patients that participate in our intervention, even just with Health Smart program, but hopefully eventually we can show if we give them this whole umbrella or this whole constellation of care that these patients are going to be doing better. And we can show that just simply with cost outcomes, but then we can also go in more focused studies looking at quality years and cost. So our hypothesis is that total direct medical and patient out-of-pocket plus non-medical expenses will be lower among Health Smart participants compared to usual care. That quality years will be significantly greater for Health Smart participants compared to usual care. And if both costs and quality years are greater among Health Smart participants, we'll estimate the incremental cost effectiveness in Health Smart versus usual care. And that's one of the things I found in that earlier study where I said it was like for a Health Smart participant, it wound up saving the insurance company, like say $250 annually per patient. And I think we can do much better than that. The impact in my mind is that the results will provide health insurers and payers, patients and policymakers, especially with information to drive reimbursement insurance coverage for mental and behavioral health care in the community. These results can be generalized to the community because our study will be utilized comparisons of what's actually happening in the real world. And I think that's the advantage of doing this work in our nonprofit setting. It is a clinic, it's a research clinic. So in sum, I hope that you've heard that nonprofits may be a great way to disseminate proven clinical interventions. It's not only possible but important and satisfying to do research outside of an academic setting. I've actually had a lot of fun. I think I'm working harder than ever, but I love what I do. And I think that if we can show that psychosocial intervention can reduce the very expensive cost of cancer treatment, that may help us get our proven interventions into the clinic as standard of care. And patients will benefit. I mean, I think morally we need to be doing this. We know we can make a difference, and we should be making a difference with psychosocial interventions. And so this is the road ahead now for us. We need to continue to grow. I really want to get a mid-level, like a nurse practitioner or a PA, to be our integrative medicine consultants. So they'll meet with the patients at diagnosis, figure out where they're at, what kind of integrative support they need, and then track that. And that way we could stamp them with our NPI number at that visit, and then just see how well does integrative medicine support make a difference in cost outcomes, just tracking them with claims data. I also want to work with other nonprofits and academic institutions to reach our goal, which is making this sort of work standard care. I tell everybody that we're like a kindergartner. We're about 5 years old, and so that's great because we can dress ourselves, and we can go off to school on our own, but we're still pretty little and still pretty new. And so that's what this is. This little thing here. This is kind of how I feel like we are. We're a kindergartner, and we've got this long road that we need to traverse to get to this place where we can provide total wellness care for cancer survivors and their families. I think that's all. Yep, that's it. Does anybody have any questions? Looks like I allowed a little time, and I will stop sharing this.
Thank you so much, everybody. Feel free to put questions you have in the chat or unmute yourselves, whatever you like.
Hi, Dr. McGregor. This is Bill Pearl.
Hi, Bill.
I was at University of Miami for a couple of years, and the way I would hear Mike Antoni talk about you and your work, I actually thought you were still at the University of Miami.
Oh, in my heart, I still am. I definitely still am.
So it's just funny to see that how much your work has made an impact both there and other places. I think you bring up some really provocative ideas about what kind of information is most useful for uptake of services, which is something that I think a lot of people struggle with everywhere. And like you said in your talk, I think early people thought if we could just show these biological connections, then people would believe how important this is. And that's been shown, and it hasn't made a difference. That I think what I have, the older I get, the more I realize the power of patients. And I think even your story of the nonprofit shows that, of people appreciating the work and advocating for it, of experiencing and advocating for it. So in addition to working on payers and insurers and policymakers, of helping to empower our patients who get our services to be advocates for it, I think is another area.
That's absolutely right, and our patients do. I think that's I didn't even mention it, but that's our biggest promoter right now, because our patients go back to their primary care docs and they tell us about it. So we are well known by the different providers. There's like 3 big groups. There's Kaiser, there's Virginia Mason, actually 4, Swedish, Providence, and then the UW Medical System and the Seattle Cancer Care Alliance and Fred Hutch, and they all know about us. They all send us their patients. We're like the Switzerland. And they see that their patients are doing better. So it is, I think you're absolutely right. And I think I tell my patients to tell their doctor about us. I mean, if you're having a good experience, I say, well, let your doctor know, because I think we need to make sure that other patients are aware of this. They don't even know that they need this or that it can help. And I think that's the hardest, that's the toughest part. When year did you leave Miami?
So I was there between 2016 and 2018.
Okay. Wow. So fresh. There is a nice Miami-Boston connection, I think. That's pretty cool.
And Christina Pozo-Caterman from University of Miami is going to be joining our faculty in August.
Oh, cool. That's very cool. I know her. Very cool. And Tim Sanis is there. He worked with Deidre Burns, who was at Florida, and she's a Miami person. So yeah, it's like this ripple effect. It's like a underground network of very great colleagues to have. So it'd be fun to come out there next time. I didn't see, how are these services paid for at Orion now? So right now they are paid for by insurance. They are paid for out of pocket. And I will say we do have a definite bent toward high SES patients right now. But we are now right in the middle of doing our Give Big Washington campaign, which is for the first time funding a patient care fund. And so with that patient care fund, the patients will still have to pay something for their services. But if you don't have insurance to cover acupuncture, then there will be a flat rate that they pay. And the patient care fund will make up the difference to pay the provider. So we're just recruiting for that, or doing our fundraising for that now. So that's, I know when I first started Orion, I interviewed the Integrative Medicine program at Dana-Farber and at MD Anderson, and both of them had about 50% of their operating budget was philanthropy. I think we can do better than that because Washington State does a pretty good job of reimbursing for naturopathy. We don't have naturopath, but we work with a lot of good oncology boarded naturopaths. But they do reimburse pretty well for acupuncture and massage and things like that. But some patients have such high deductibles or their insurance doesn't cover it well. We will have this patient care fund now. And the low-cost psychotherapy with the students is actually helpful because most of those people that take advantage of that are younger. And so they like working with the younger providers. Not that we're old, but it helps. So lots of different ways, and we're working on making more ways. I think ideally, I think that I'm trying to figure out the best way to reimburse for this. I think if we do start seeing payment for outcomes being the way that health insurance is paid, or that patient care is paid for, I can see hospitals wanting to have us on board to be part of that care team so that it will reduce their costs. But I mean, I think that's the big question, like how do we pay for this stuff? Any other questions? I should look in the chat box and see. I just watched a live stream and there were all these questions floating by. You can just speak up too. Is anybody there working on the stress management and resiliency training program? I know Dr. Najad was out here. I don't know if you guys know him, but he came from Dana-Farber and then was at Swedish directing their psychosocial oncology program for a while. And my understanding was that there was this stress management and resiliency program there. It sounded like you were taking the Miami Cognitive Behavioral Stress Management program, had made it into your own little 8-week thing, and then we're trying to disseminate it that way. And I was really curious about how that was going. I actually gave a talk at Swedish with Dr. Najad's group, and there was a couple people from Boston there that were talking about it. Is anybody here familiar with that?
Shamim is actually from MGH and not Dana-Farber. So we have a complicated relationship. We're part of the same overall Harvard Dana-Farber Cancer Center, but we're separate institutions.
Got it.
So over at MGH, they have a lot of UMiami people like Lara Traeger and Jamie Jacobs and Connell O'Cleary. Park has been working a lot with the Benson Henry Center and have created something a little similar to the Miami program that they've kind of rebranded like stress and resiliency.
That's it. Thank you. Oh, I'm so glad you clarified. It's been so confusing from over here on the West Coast because, you know, just like I think all the states on the East Side are all kind of like a conglomerate to me. I didn't understand like what was going on there at Boston. So thank you. And my apologies for that faux pas.
So we always are happy to take credit for the stuff that they do. They're always upset when they get identified as Dana-Farber people. So it's funny from being a former MD.
Be strong. Dana-Farber is cool. I mean, when I was there interviewing with the integrative medicine person, it was, you know, do you guys collaborate with the integrative medicine folks at all?
Just a little bit.
Linda, did you want to say something? You look like you're like trying to communicate with me through the screen.
But you're on mute. Yeah.
No, thanks. I agree. I think it's a great program, the integrative medicine, but we don't seem to collaborate a lot. I'm not sure why, but it's a great program.
I find that I really enjoy having, I send my clients to the nutritionist. She used to be at SCCA, and Dana Boberg showed that peripheral neuropathy also impacts our gut nerves, and that you see a lot of digestive problems in people who have peripheral neuropathies. And Gretchen's really great at helping people with gut issues, and acupuncture can make a difference with peripheral neuropathies and nausea. And I love working in that supportive care team. And I think it's just, I think it makes a lot of sense. And I think that we're all kind of under the palliative care umbrella. And I just think there's so many opportunities to be able to work together like this. So, but Tim Sanis is working for Dana-Farber. I do know that for sure.
Yep, I hired him. So I know that for sure.
You did. Well done. Well done.
Uh,
Yeah, no, that's great. And it's
So,
good to know
so
about
thank
the
you.
MD.
Thank you so much, Bonnie. We're actually out of time.
Okay.
But thank you so much. It would be great to